Welcome to the Liver Lounge, your go-to podcast for the latest updates in hepatology, featuring discussions with the world's leading experts.
Hi, thank you for listening to this podcast by the Liver Foundation. I'm Dr. Margaret Ting. I'm an attending in National University Hospital from Singapore. And I have here with me today Dr. Anahita Rabiee. She's a hepatologist from the West Haven VA Medical Center, and she's also at the Yale University School of Medicine. So thanks a lot, Dr. Rabiee, for agreeing to join us today. Today
Thank
we'll
you
be
for having me.
discussing, I think she's recently published an article in Hepatology Communications earlier this year on the medications for alcohol use disorder improve survival in patients with hazardous drinking and alcohol-associated cirrhosis. So this is a great study. I think it kind of sheds a lot of light in a often neglected group of patients, those with alcohol-associated cirrhosis. So thanks again, Dr. Rabiee, for joining us for this interview. I guess to kind of set the stage for our discussion, maybe you can tell us a bit about what is alcohol use disorder and also the prevalence of alcohol-associated cirrhosis globally and also in the United States.
Absolutely. Thank you for having me. So alcohol use disorder is basically a medical condition that the patient, despite is not able to stop or control their alcohol intake, despite the fact that it's causing them social, occupational, or actual health consequences. So we need to start thinking about it as an actual medical condition and be sure that we are using the correct terminology because we don't want to, cause stigma so patients are not seeking care. In terms of the prevalence of alcohol-related liver disease, kind of the entire spectrum, not necessarily just cirrhosis, worldwide, it's about 5%. In the United States, reports are different, but I would say it's about 8%. And alcohol-related cirrhosis has actually been on the rise among the different spectrums of alcohol-related liver disease. There is data from NHAIS database, which is a kind of a national database in the United States, that alcohol-related cirrhosis is around 6.67%. This was from 2015, and it's been really on the rise.
Okay, so I think that's a really good kind of introduction to the rest of our discussion. So in patients with, I guess in patients with alcohol-associated liver disease, that's probably something that both you and I see quite commonly. Can you describe some of the challenges that they may face in terms of getting access to care, and also how do you normally treat these patients with alcohol-associated liver disease and alcohol use disorder currently?
Absolutely. So I feel like there is really a gap between, the hepatologist and being able to manage the addiction, because the alcohol addiction is, the most important intervention you could do for these patients so that they would stay away from alcohol. A lot of patients who come in with alcohol-associated hepatitis, if they stop drinking, their ascites will go away, their liver enzymes will normalize. So, it's really, really effective treatment to help them stay away from alcohol, achieve complete abstinence. However, I feel like hepatologists are a little hesitant to manage the addiction part. And then when the patient goes to addiction medicine, they're also hesitant to prescribe medications to patients who have cirrhosis, especially if there's any decompensation. So, then the patient kind of is left in between. So there are models that, you have addiction medicine and hepatology in the same clinic. So as soon as you're done chatting with the patient, you walk the patient over to the addiction medicine doctor and they will talk. So that is great. However, it's really not practical or feasible to think that could be the model everywhere. So, with the fact that alcohol-related liver disease is really on the rise, and now that we have treated Hep C, this is the majority of patients we are seeing, along with patients with metabolic disease, in our clinics, I think as hepatologists, we should be able or comfortable to start treating the patients right then and there. Because when you refer them to addiction medicine, it's unclear if they're going to show up. It's a different doctor, they're already pretty burdened by their disease. So when you have the patient there, it would be great if the hepatologist would take the initiative and actually prescribe the medication for the patient.
Great. So I think that sets us up very nicely to discuss your article. I think maybe you can tell us a bit about how the study was designed. And I think in your study, you also mentioned kind of how often medications for alcohol use disorders actually prescribed in these group of patients. Yeah.
Exactly. So in this study, we used the Veteran Health Administration data. There's a large database called VOCAL, Veteran Outcomes and Cost Associated with Liver Disease, which has the information on patients who have diagnosed cirrhosis. So among this data set, we were able to, and then VA, as part of their routine care, they use Audit C, which is a screening tool to identify patients who are having alcohol-related problems. So we looked at the patients who had cirrhosis related to alcohol. It could have been plus or minus Hep C or other causes, and had Audit C of 8 or above, which is really hazardous or high-risk drinking in the year prior to diagnosis of their cirrhosis. So Audit C is considered positive in men above 4, but for this study, we really wanted to look at the very high-risk group. So that's why we chose the Audit C being greater than 8. And then we looked at the initiation of the medications for alcohol use disorder in the year after their diagnosis of cirrhosis. And then we followed them after the first year to see what are the outcomes. In terms of outcomes, we decided to look at all-cause mortality. First, it's the cleanest outcome that you can look at in a large data set because it's much more accurate than, let's say, liver-related mortality. The other reason was, at the end of the day, alcohol can cause death or mortality with many different mechanisms. One of them is liver decompensation, but, a patient could go into motor vehicle accidents, falls, withdrawals, or other things that might be contributing to this. In terms of the medications for alcohol use disorder, there are the FDA-approved ones, and there are the ones that are not FDA-approved or used kind of off-label. In patients with cirrhosis, baclofen is the one that has the most data, and there has actually been randomized trials on baclofen. However, in the addiction medicine world, baclofen is not the first thing you would reach for. It's actually, there are studies, systematic reviews that, again, this is not in patients with cirrhosis, in just general population with having alcohol use disorder. There are meta-analysis looking at randomized trials. There was one that looked at 14 randomized trials. It actually didn't show any benefit versus placebo. So that's really not the medication that most people go for in addiction world. The other thing is when you're looking at large administrative health records data set, it's very difficult to figure out why was baclofen prescribed. Was it for neck pain or was it for alcohol? So that's why we decided to kind of stick with the FDA-approved ones, which are acamprosate, naltrexone, and we excluded disulfiram because it really shouldn't be used because of risk of hepatotoxicity in patients with cirrhosis. So that leaves us with acamprosate and naltrexone. So that was the medications that we focused on because really they don't have much other indications. And when you see the patient on these medications, you can it would be a reasonable guess that this is for alcohol use disorder. And then when we follow these patients, the ones that received either of these medications during the first year after their diagnosis of cirrhosis, after that, the hazard ratio was so basically patients who used what I'm going to call MAUDs, which are these medications for alcohol use disorder, after diagnosis of cirrhosis in the first year, that was associated with 20% reduced hazard of all-cause mortality during follow-up. And we also did a time updating analysis looking at, so basically each patient would contribute data when they were taking the MAUD as someone on MAUD and when they were not as someone off MAUD. And it would be updating every 30-day going forward. And we also time updated for age, decompensation, and depression. So during the window or that 30-day time window that you were on MAUDs, it was associated with a 68 reduced hazard of all-cause mortality. So that's also pretty impressive. But you could argue that when the patient is on this medication, most likely they're a little healthier outpatient. And then the last part that I wanted to add about our study and how it's different from other studies, I think there is a lot to say about healthy user bias, that you start these medications on patients who have less severe liver disease, they're not decompensated, or they're, have more engagement in healthcare. So we tried to adjust for all that by using a propensity score matching. So first, we looked at the differences between patients who received MAUDs and the ones who didn't. And there were major differences. So patients with decompensated cirrhosis were much less likely to receive it. And patients who had an admission for alcohol use disorder or had concomitant mental health disorders such as depression or substance use, they were much more likely to receive these medications. So we try to adjust for all that by doing a propensity score matching. So we are not, really what we are observing can be, would not be biased by healthy user selection of the ones with MAUD.
Okay, I think that was a really nice summary of both the study design and the results. Just out of curiosity, especially for international listeners, because you mentioned that audit C is something that the VA Medical Center does, or your health system does for patients. Is that something that is done routinely for all patients? Like all patients are screened for alcohol use disorder, or is that something that is targeted mainly at those that already are at risk, like those who have liver disease?
Actually, it is recommended. So at the VA, it's done for everyone, basically. So the primary cares are usually the ones that do it at least once a year. It's a way to screen who is having, potentially dangerous or high-risk drinking. And then based on the score that the patient gets, they would be referred for, more interventions, or the primary care might take the initiative and do the intervention. I think it's not as regularly done in many other healthcare settings, but the VA has a very good system of, basically there are reminders that show up when you're seeing the patient. For example, patient is due for the colonoscopy, patient is due for alcohol screening, patient is due for Hep C screening. So they all show up. And I really think it should be either performing audit C, which has been validated and it's like 4 simple questions, or any other questionnaires that people want to use, but it's important to ask. And I would say that the best way of approaching it would be asking and recognizing this much earlier than when the patients actually end up with liver disease. So it would be mostly on primary cares who are seeing a patient who their liver is healthy, but they're just starting to drink heavily. It's a 20-something-year-old. So that's when you want to really catch it and prevent it from getting to the phase that they already have liver disease. But, even at the stage that they already have established liver disease, even decompensation, still there is a good role for starting the medications and prevent them from, mortality or developing further decompensations.
Yeah, so I think you made a really good point. I think the VA has done something that I think other healthcare systems could probably learn from, in terms of screening all our patients for alcohol use disorder, especially with the increasing prevalence of alcohol-associated liver disease. I think moving on, I just want to ask you a bit about the study results. So I think in the study, it's also mentioned that, there is a kind of a dose response effect where longer durations of malt exposure is actually associated with more improved survival. But I don't know in the data, is there any data on the compliance to the medications, or also the dose like they were taking? Were they taking it regularly every day, or was it taken for like 1 month, 3 months, or 6 months, and then they stopped it? Yeah.
Yeah, so we can see the pharmacy refills, and that's the way kind of we were able to see who got these medications. But in terms of compliance, because it's just large data set that we're looking at, it's not like we enrolled individual patients. So there's no way for us knowing that if they actually took the medications or they didn't. In terms of the dose response, like basically what we mean by that is like the longer duration is associated with better outcomes or more prominent decrease in mortality. In terms of the optimal duration, there is really there's not like a certain duration that has been studied and is recommended for patients. Most kind of references that I looked at least recommend a minimum of 3 months. And, recommendation would be the longer the better, at least a full year, because during that first year is when you have a pretty high risk for relapse. So I think that if the patient started on the medication and they are doing well, medications have very, very minimal side effects. So I would continue them for at least a year. And, I would even argue longer might be better.
So I think the main points of the study would be, I guess, that obviously receiving malt is associated with improved mortality, and of course, the longer that you take it, the better the outcomes. Can I just ask, in your clinical experience, why would malt be underutilized, and how would you select patients for use of malt?
Yeah. So it is really underutilized, and it's not even just in patients with cirrhosis. There was another study looking at, Veteran Health Administration data, looking at patients who had alcohol use disorder. Not, they didn't necessarily have cirrhosis, like everyone with alcohol use disorder, and it was prescribed about only 3% of the patients. So, it is underutilized. I mean, you look at cirrhosis per se, it's even worse than that. The reason in our study, it was actually a little higher percentage. It was about, I think it was about 9%, was that we really selected the highest risk group. So, but even in that population that their audit sees almost through the roof, 9.7% received only at least 7 days of MAUD. So it is really underutilized. I think that, it's a whole separate study to look at what are the barriers for underprescription. I think at least among the hepatologists, I have a sense that there's one that, you're not really that familiar with these medications. It wasn't part of the training. And there is also, I feel like people don't really believe that these medications are effective. So there's a nice randomized meta-analysis looking at all randomized trials using some of the FDA-approved medications, such as acamprosate and naltrexone. And this is a little bit older in JAMA from 2014, so there might be better, newer data. But that one basically shows that for acamprosate, number needed to treat to prevent return to any alcohol use was 12. This is not in patients with cirrhosis. This is just randomized trial of patients with alcohol use disorder, which I don't have a reason to think that it would be different in patients with cirrhosis. But, number needed to treat being 12 in patients with alcohol use disorder, that's pretty impressive. For naltrexone, again, the number needed to treat was 12 for preventing them to going back to heavy drinking. And if you think about it in hepatology, for example, the Predesi trial, we thought that, number needed to treat was 9 to prevent 1 decompensation. So, I think it is effective because now we're all doing the beta blocker thing, but this one, it's not doesn't look to people as appealing, but it really works, especially if patients are on it longer term and they have a more closer follow-up with their hepatologist or whoever is managing them. I think it might just be a missed opportunity that when we have the patient, we really need to start talking about this and prescribing it. Naltrexone is, much easier because it's once a day. Camproside is 3 times a day. So usually compliance with naltrexone is a little better. But again, it's patient preference, and also, depending on their other comorbidities, you might decide for either of those.
Yeah, so it sounds like number one, it would probably be our hepatologist training. Although we see a large group of patients with alcohol-associated liver disease, we may not have received the training in our fellowship to prescribe these medications, and certainly that holds true for the healthcare system I come from. The second thing, I guess, would be I think a lot of providers are kind of hesitant because some of these medications are associated with hepatotoxicity or decompensation. So, like as you mentioned, disulfiram, but I think also in already decompensated patients, there's a lot of hesitation in the use of these medications. So, I mean, focusing on this particular group of patients already decompensated, and they need to stop alcohol use to kind of improve their outcomes. How would you then kind of recommend treatment? Would you still recommend more in this particular group of patients?
Yeah, so I'm actually glad you asked that question. So we have another study going on looking at patients who receive naltrexone and doing like a very in-depth chart review to see if there was actually, because we have a large cohort of patients who have received this medication at the VA, to see if there is any signal for hepatotoxicity. Study is in process, so it's not done yet, but so far we haven't really seen much. But again, we haven't completed the study yet. It's all retrospective. I think there has been a little hesitation specifically about naltrexone because the camproside is like really renally cleared and should be like, it is really safe. It doesn't really get cleared through the liver. However, even with naltrexone, especially the oral form, you might see some elevations in liver enzymes, but true hepatotoxicity or naltrexone causing the decompensation is extremely rare, and it's also unclear if it was naltrexone or going back to drinking or whatever. But on the other hand, we know that continuing alcohol, that is gonna make them further decompensate and die. So I think that we really don't have great evidence showing that it has dangers. In terms of the IM naltrexone, which works well because it, gives the patient 30 days and they don't have to be compliant taking it every day. So that's a really good option. However, in patients with decomp cirrhosis, I think there is not much data about its safety. So I think most people avoid the IM naltrexone, which I agree. I think we need more information before starting to use that in patients with decompensated liver disease. However, I think the oral naltrexone with closer monitoring, kind of bringing them back in a few weeks, just double checking the liver enzymes, I feel like the benefits definitely outweigh the risks.
So I think I really look forward to that study, so that that may be something that's key to getting the hepatology community to use naltrexone more commonly in this group of patients who might benefit the most. Would there be any other strategies that you think we can employ to encourage physicians to kind of start prescribing these medications in patients with alcohol-associated liver disease?
I think that training, like having this as part of the training for anyone practicing, like, it could be the primary care, the gastroenterologist, the hepatologist, so people are more comfortable with these medications. So being part of training would be very helpful. again, obviously having health systems or clinics that there is some integrated care. So there's an addiction medicine person or a psychologist or someone there, that is also extremely helpful because, I don't really expect hepatologists to know how to do like behavioral therapy for alcohol problems, right? And the visit is usually focused on other stuff. So that would be, the best approach, to have both the pharmacotherapy and also the behavioral therapy. It's obviously going to be more effective, but at the least I feel like the pharmacotherapy is the part that everyone should be trained and be comfortable to give to patients. We prescribe medication for everything else. Like this also needs to, be part of our practice.
Okay, that's great. So I think thanks a lot for your time, taking time to do this interview for the Liver Foundation. And are there any last comments that you want to make for our listeners regards to your study or about alcohol-associated liver disease in general?
No, just thank you for having me and, having, kind of bringing more attention to this topic. I hope that this maybe inspires some hepatologists to start reading about these a little more and then prescribing it. I think if we make that change, that would be amazing.
That's great. Thanks a lot, Dr. Rabiee.
Thank you.
We have come to the end of the episode. Thank you for joining us and stay tuned for more captivating discussions.